Welcome to Coffee and Community Cutaneous Lymphoma Conversations, brought to you by the Cutaneous Lymphoma Foundation. I'm today's host, Holly Preet, and glad to have you with us. Joining me today is Professor Chalid Assaf, Director of the Department of Dermatology and Venerology, Head of the Comprehensive Cancer Center of the Helios Hospital, Crefeld. So please grab your favorite cup of coffee, settle in as Dr. Chalid Assaf and I discuss the newly developed and accepted guidelines for pediatrics in cutaneous lymphoma. Welcome, Professor. Thank you for joining us today.
Thank you. Thank you too.
So, help our audience understand what are guidelines, who uses them, and how do they help?
So the guidelines are, of course, for all doctors who are treating children with cutaneous lymphoma, especially with mycosis fungoides. And this includes not only dermatologists, of course, also pediatrician, hematologist, oncologist. So all doctors who are interdisciplinary responsible for these children. And the guidelines covers the whole field of this topic of patients with mycosis fungoides, from the diagnosis, from the staging, and also regarding the treatment.
So, how do they help a physician when let's just say, a new patient comes in? What is the benefit of having these guidelines in place?
Cutaneous lymphoma, especially mycosis fungoides in children, is quite rare. And that's why these children are usually included with the adult patients of cutaneous lymphoma. And they are behaved also the same, including the complete diagnostic, staging, and also the treatment. And this is often, let me say, too much for the children or unnecessary, because you have to recognize that children have special clinical features, also histological features. And maybe the most important information is that children with mycosis fungoides usually have a very good prognosis. So very rarely transform to an advanced stage. Said this, that means this should also be respected for the staging analysis and also for the treatment. And this guideline helps also to know that the clinical features or the presentation of mycosis fungoides in children are often quite different from that what we see in the adults. In fact, children often present with hypopigmented lesions. Lesions are uncolored. It looks like having vitiligo or like a fungal disease, which is often mixed up with this special form of mycosis fungoides. And this so-called hypopigmented mycosis fungoides is the most common subtype or most common form at all in children with cutaneous lymphoma. And this we see very rarely in adults. So this is a clinical feature is very important to know, especially for the differential diagnosis, and to include it and to go on to take a biopsy and to have at the end a clear diagnosis. The same also is for the histopathology. Usually in adults, the mycosis fungoides originates from T lymphocytes, which are CD4 positive. And the CD8 positive cells are usually the reactive cells. But in children, it's the opposite. The most common forms of pediatric mycosis fungoides are CD8 positive. So the malignant cells are CD8. And this is very important to know that this is very typical and important also for the diagnosis. There are also points regarding staging and treatment. If you want, I can go further, but maybe you have other questions. Could go in more in detail.
Well, I'd love for you to go into additional detail. And then I also want to circle back to ask about the hyperpigmentation, if that is in all skin colors or if that's specific to darker skin tones.
That's a very good question. So it is mostly hypopigmented, so less pigmented. And in general, we can say that mycosis fungoides in children mostly occurs in pigmented children. That means these are children originally from the Middle East, from Asia, from South America. And for this, we have quite good data that also in this region, mycosis fungoides in children are more common as compared to Europe, as an example. We have no information about the situation, how it is in Africa and black skin. Um, but I assume that there it plays also a role. There is indeed overt special geographic distribution of Mycosis Fungoides in pediatrics in children.
So, what is the process that you and your colleagues go through for developing guidelines? I'm sure that it didn't happen overnight. I'm sure there's a lot of research and things that go along, but what does that process look like?
It's a long process. So it took us about 3.5 to 4 years, and my colleague, I have to mention her, Professor Emilia Hudak, and myself, we were steering this process over this whole time closely with all 3 large, or biggest societies for cutaneous lymphoma, which is the International Society of Cutaneous Lymphoma, the American Consortium for Cutaneous Lymphoma, and also the European Organization for Research, Treatment of Cancer. So all these colleagues from all over the world, we developed it in the time of about 3.5 years, and it's a process which has several steps. We're starting initially with questionnaires, asking about the experience of the colleagues. This was one of our first questions, and then were asking about the population of the children who have this mycosis fungoides, the typical clinical presentation, typical histological presentation, and also the experience, how often they see advanced stage, how often they see early stage, and also regarding the treatment. First step was the questionnaires, then we had a face-to-face discussion, but also compared with a hybrid meeting at the AOTC meeting in Marseille in 2021. And then we had further rounds of questionnaires till we defined the clear criteria for the diagnosis, which I mentioned as an example, the clinical presentation, the histological presentation, but also what is needed for staging and for the treatment. And to go more in detail, as children usually have a good prognosis and they stay lifelong in the early stage, intensive staging analysis like CT scan or PET-CT is usually not needed. So these are, of course, important investigations we use in adults because adults have a higher chance for progression of disease. But this is something very rare in children. That's why we don't need this intensive staging analysis where patients get also radiation just from the staging analysis. And we have to always to keep in mind these are children. During the long time of their life, which they have, the radiation could also have negative effects in inducing new cancers. And that's why knowing that these patients have a good prognosis, they stay usually in the early stage, CT scan, PET-CT is also not needed. The same for lymph node biopsy. Lymph node involvement is very rare. On the other side, we know that children often have enlarged lymph nodes once they have an infection. That's why we have a strategy of watch and wait integrated in our guideline. And before taking a biopsy of the lymph node, which is really very rarely needed. And you see already at the first glance that there are big differences to that what we are doing in adults, and all in favor of the children that there is no need to be invasive. They don't have a benefit from it.
Yeah. So you mentioned, Professor, about watch and wait. We have parents who say, "How can you watch and wait? This is my child." Right? Is there further explanation? I know that clearly you just mentioned about an aggressive approach. You don't want to get too aggressive when it's unnecessary. But can you explain a little bit more about including that particular terminology and what a parent should take away from that description?
There are two things. Watch and wait regarding the staging analysis. Once we have an enlarged lymph node, that was the point I mentioned. That means you have to check if there are not other reasons why the lymph node is enlarged. Usually they have a bacterial or viral infection. We check for inflammation markers. You can do ultrasound of the lymph node, and maybe you give, if there's a bacterial infection, antibiotics, and then you can repeat the ultrasound after 2 to 4 weeks, and also the clinical investigation to check if it's back normal. So it's an active watch and waiting. And of course, it's very important to inform the parents that regarding the prognosis, that they also understand why we are not need to be aggressive, neither in the staging analysis, neither in the treatment. And regarding the treatment itself, as I mentioned, that usually they have patch and plaques, very rarely tumors. So early stage mycosis fungoides, skin-directed treatment is a treatment of choice. So Once we use skin-directed treatment. This means like topical steroids or other treatments which are working against cutaneous lymphoma in the early stage, like topical tacrolimus, topical pimecrolimus, in combination with phototherapy. And for phototherapy, we have also a lot of choices. So in adults, usually we prefer PUVA phototherapy. So it's a combination of psoralen, which is a photosensitizer, which is a drug, usually a tablet, which is P, in combination with UVA. This is called PUVA. It's very old and very effective, still very effective, and first-line treatment for all early-stage mycosis fungoides. And in children, it's a bit different because this photosensitizer could have adverse effects the eyes, and it's difficult to tell the children you don't have to go out to the sun. So the compliance is difficult, and sometimes it can have also gastrointestinal side effects like nausea, stomach, and so on. And that's why in children, we prefer the phototherapy using UVB. This
Oh.
is first line treatment without the combination of any systemic treatment like the psoralen, but there's also usually not needed any systemic treatment like retinoids or interferon or methotrexate. So this is the approach for, let me say, for the most cases of children with having mycosis fungoides. Rarely for if they are disseminated deep plaques or if it's refractory. Only for this small group of patients, they may be considered to add an systemic treatment to the skin-directed treatment. And in this case, of course, retinoids, there is huge experience with retinoids also for other diseases in dermatology for children, like bexarotene or especially acitretin or isotretinoin. And other choice could be interferons or methotrexate. Also for methotrexate, there's a huge experience with children. As I mentioned before, usually in most cases, you don't need the systemic treatment. You can treat the children successfully with a skin-directed treatment, which means phototherapy in terms of UVB with topical steroids, as an example.
So I have a question for you because I know that it has come up before, and knowing that, you have developed the guidelines is a concern that we hear sometimes is how long can a child be on phototherapy? Is this a short term treatment for them, or is this something that in the proper dosage can be something that they can use for a more extended period of time?
Usually, it's a short-time treatment. So it's a treatment between, let me say, 3 to 5 or to 6 weeks, depending on the dosage, if it's treated daily or 3 times a week, which is most often done, and also is depending on the skin type. So the dosage is usually adapted to the skin type. Children with a darker skin have usually a higher so-called minimal erythema dosage, so they tolerate the UV phototherapy better than with a fair skin. But it's usually not a treatment which goes over months. And we also don't it's a very good question. We also do not recommend phototherapy as a maintenance treatment. So it's just for a short period, the active treatment, and then we stop it, and then we go on with the topical skin-directed treatment.
Okay, and can they come back to it if patches and plaques were to reappear and the steroid
It's
topical
possible,
treatment?
yes, it's possible. So what we know is it's nearly the same as we have in adults. So they usually stay lifelong in this early stage, but it come back and the same patches usually, sometimes black, but mostly are the patches. And then you can use the same protocol for treatment. So it's like children having psoriasis, children having atopic dermatitis. So we
Mhm.
can treat both conditions, also not malignant, very well, but usually they have it lifelong, so relapse is very common. This is important to know. Next point, which is important to know, once children have a relapse, it doesn't mean that it's now starting to get aggressive or that it go to the advanced stage. No, it's still the same early stage, and you can be calm and treat it with the same procedure as you treated initially, the pediatric mycosis fungoides.
That is good to know that it may not be a progression just because it comes back. It just may be a reoccurrence. So
Yeah.
you had mentioned a little bit about I know it took a really long time to get the data and develop the guidelines that you currently have. Will the research continue and continue on to include more and more geographic regions and more pediatrics from around the globe? Or is it kind of a one and done?
No, no, of course not. I think this is the beginning. I think with this guideline, our primary attempt was, of course, also to increase the awareness that this mycosis fungoides occurs also in children. We have to include it as a differential diagnosis. And with this awareness, we already started further research programs. One is within the EOTC. We are now looking within the EOTs, the frequency and the subtypes of cutaneous lymphoma in children, and also to get experience about the long-term outcome, what happens when they are getting adults and so on. There's still a lot of questions. We started in Europe, and we started also the same question in the so-called MENA region. We have established a cutaneous lymphoma group 3 years ago in the Middle East and North Africa, where this disease is most common. And also, we just started to collect the information, to collect the data, to understand a little bit also more the regional differences, and also maybe based on this to get an idea if it's just the difference in the color of skin, or if there are regional differences also, which has environmental factors as an example. So
Mm.
we still don't not that much about the pathogenesis of the Mycosis fungoides in these children, and I think it's very important to know, and especially once we have regional clusters, I think from there we can learn a lot. You know, in the Middle East, Mycosis fungoides in children is about 15% of all cases of Mycosis fungoides. And if you go to Asia, like Singapore, from their registry data, we have the information that about 25% of all MF cases are under 18 years old, are
Wow.
children. So they are clusters, and we just started. There are a lot of questions we have to answer, and that's why it's so important to go on with this topic, and initially, at least, to get them as much information as we can over the globe.
We agree. Every time we get a parent who reaches out to the foundation for support and education and really hope, which is what you and your colleagues are providing to the people, who call us, is why does my child have this and what is the long-term effect on their life, right? So we are so grateful to you and your colleagues for the hard work that you do to try to figure out cutaneous lymphoma diagnoses in pediatrics. What, as a scientist and a professor in cancer and cutaneous lymphoma, what is it that you hope that parents and people affected by cutaneous lymphoma know about the work you're doing and the need for continued work?
Yeah, first of all, what they have to know, especially the parents, is to be with this information not afraid. This is the most important thing because for the parents, often more than for the children, it's often a shock once they have a diagnosis, oh, cutaneous lymphoma. And this is usually has the most impact, the diagnosis. And the information is not always, or still not that good distributed, that these children can be treated, that there are a lot of treatment possibilities, and that disease itself has a very good prognosis. So this information, I think, is the most important information which has to be shared from the beginning with the parents. And on the other side, that is something chronic. So it's not a disease we treating for 4 weeks and then it's forever gone. It is something chronic, but it's something which the children can live very good with. I think that's the most important information regarding the parents. And yeah,
That's great. And what I took away from some of the treatments that you included in your guidelines, PUVA versus light therapy, you considered their capacity to be compliant with treatment, which I think is also equally as important. When I was hearing your guidelines, is there anything else that I missed, or maybe that I didn't hear? What kinds of things are important for people to know about these guidelines, other than it's amazing that we finally have?
I think this guideline is a very good example that this cooperation, worldwide cooperation of experts, not only which is in our guideline also interdisciplinary. So we have included not only dermatologists, there are hematologists, there are pathologists, there are pediatric hematologist, oncologist. And this is a very good example that this worldwide cooperation is very successful and provides very important information for the patients. And I think we have to go on, especially in this rare disease with this way. And I think it's one of the rare examples till now where all three societies work together and produced such a guideline. But we showed that it's possible. And I hope it's just the beginning.
We absolutely are so grateful to you and your colleagues for the collaborative approach to ensuring that people with cutaneous lymphoma, and in this instance, the pediatrics with cutaneous lymphomas, are at the forefront of the science and making sure that their needs are being addressed and met. And we are forever grateful. And I will say that I no doubt we will be in touch for follow-ups and staying in close contact to hear any new outcomes that you may be having, or new engagement that you need from the patient population, because we're always happy to share what work you're doing on behalf of people with cutaneous lymphoma, and make sure that we continue to support you in your efforts. Is
Thank
there
you.
Yes, absolutely. Is there anything else before we close out today?
I think that's fine.
Wonderful. Thank you so much for your time, Professor. That brings us to the end of this episode of Coffee and Community Cutaneous Lymphoma Conversations regarding the pediatric guidelines. We hope, as an audience, that you found this discussion with the professor very insightful and inspiring, as I did. And before we go, one last thank you to Professor for his commitment to people affected by cutaneous lymphoma.
Thank you too. Thank you.